right, so this is a case that I'm sure many of us kind of deal with. This is a case where I have a patient who essentially presented from an outside clinic. And I know that we all acquire patients from all over, and we don't have the benefit of having years worth of data like just this case. So this is the patient that I acquired with a history of chronic angle closure glaucoma, previously managed in an outside eye center, and presented to us with a history of an LPI back in 2018. Previous history of treatment with latanoprost and brimonidine, and he was most recently taking rocklatan twice a day in both eyes. In another medication, however, he's been off medication for 2 months. He recalls that his pressures actually have been in the low 20s despite being on eye drops. So our thought is his eye pressures are probably in about the 20s Tmax without any medication. He feels that the eye pressure lowering medications are ineffective in terms of lowering his eye pressures, which kind of led to variability in how he's taking the medications. He has an unknown family history, he was adopted, and we weren't able to get a lot of his previous data from the outside providers. He was seen at our eye clinic back in 2020, and I acquired him in 2021, so the data that I have is from early 2021. So when I saw him in my glaucoma service, you can see that he has good vision without any corrections. He's not a myope or a very high hyperope. His eye pressures in office were about 20 and 22. And again, he's been without medication for 2 months. So this is essentially what I assume that his Tmax is. He underwent LPI temporally in both eyes. And as you can imagine, in someone who has a history of chronic angle closure glaucoma, it's quite appropriate to do an LPI. If you recall from the ZAP study, those patients were primary angle closure suspects. They did not have glaucoma. If your patient essentially has glaucoma or evidence of PAS, I think it's absolutely appropriate to get this patient in to get an LPI as soon as possible. Looking at his gonioscopy, and I think it's always important when you're classifying disease to look at the gonioscopy readings. And as you can see, that this patient does have some PAS superior nasally in both eyes. I'm going to show you some anterior segment OCTs here in a moment as well. Of course, you want to look at the back portion of the eye. So let's have a look at his optic disc photos. Don't know how well they show up on the Zoom here. However, as you can see, this patient does have significant cupping in both eyes. He actually has large size optic discs in general. Again, probably doesn't show up that well on the Zoom screen, but you can kind of see that he does have some nerve fiber layer reflection here, but really no nerve fiber layer reflection on that inferior areas in both eyes and superior in that left eye. The other thing that I look at with photographs, and Jess mentioned this in her case as well, is that it is very important because I feel that you want to rule out any other type of optic neuropathy. So I'm looking for things like pallor on the optic disc. We know from the OATS study, we tend to miss things like disc hemorrhages. So taking photographs to look at disc hemorrhages are so important. This patient does have some peripapular atrophy, no signs of pallor in the discs. I also don't see any signs of vascular type changes that would indicate a previous vascular event like a BRVO, CRVO, or anything like an AION causing visual field defects. I'm going to show you those visual fields here shortly. When we look at this patient's angles, now remind you, these are post LPI. These are essentially taken here. This is the right eye here on this side, and then the left eye here on this side. You can kind of see here that nasally in both eyes, it's a little bit thin, or narrow, excuse me. Just to give you an idea on where structures would be, if you look at the transition zone between that clear cornea and that limbal zone here, this is kind of that transition zone. The scleral spur is usually about 1 millimeter or 2 behind that. So that's likely where the scleral spur is. So this is where your trabecular meshwork is. And you can imagine that, there can be areas of contact. This was taken kind of at that 180 mark. And as I mentioned, that the PAS was actually kind of at that nasal superior end. So in some cases, you can actually get some really, really good images with the anterior segment CT. I'm just wondering on the panel, how do you guys use the anterior seg OCT, or do you mostly focus on gonioscopy? And I will admit that gonioscopy for me is king, and that's what I use for most diagnoses.
I'll let Jessica first. What are your thoughts?
I rely on gonioscopy. Where I do find OCT of the anterior segment to be helpful are those cases where you really do want to document and determine true appositional closure and appositional touch. If we're doing OCT in a completely dark room, we're going to get into that mid-dilated state as best as possible versus any light going into the eye with gonioscopy. So you may kind of lean more towards appositional closure with OCT, but in general, it's something that I rarely use and do just rely on gonioscopy.
I agree. I think gonioscopy is still my go-to. It is amazing how many narrow angle evals though I get. I had a lot today, and how many times I put the gonio lens on the patient's eye and they were like, oh yeah, no one did this before. I was like, well, how did you get that diagnosis? How did you get here? And in truth, many of them probably by Von Herrick were kind of narrow, but it is, I think it depends on when you trained. So I think OCT has gotten so much better at imaging the angle that I think I don't use it enough. I use it more for teaching. It helps the patients understand what we're going to do and why a laser might need to be done rather than me just explaining. I think when I explain with images, they leave so much more comfortable with what's going on. And I'll admit, I think I've learned a lot because I was a little biased when OCT first started, being used for the anterior segment when I was finishing my training. It was in its infancy and the images weren't great. And we really couldn't image the canal well. We still are limited. We can't really see the posterior aspect of the iris as well as we like, or the position of the ciliary body, but we definitely can see the angle, in much better visualization now. So I'll say I use it anew, probably not as much as I should use it though.
Yeah, and I think both of you bring up some really good points. You'll kind of miss things like how much pigment is in the angle, if it's splotchy pigment, if there's areas of PAS on the OCT. But I think, other benefits are that, yes, you can do it in a completely dark room. No matter how gentle you are with your gonio lens, you are putting a little bit of pressure on. That could make the angle a little bit larger than it truly is in those types of dark conditions. And I think now, with the OCT getting better and better, you can also look at maybe the contour of the iris, things like lens rise, which is pretty fantastic.
I was going to say lens vault is very nice to see, and some of these other parameters. I think one thing I knew that's interesting, and just maybe moving away from imaging for a second, but just even in terms of looking at this angle, what is interesting, patients get called chronic angle closure, which is the appropriate term when they have evidence of disc damage and PAS. But I always got to wonder, with nerves like you showed, does this patient have an open angle component to what's going on here? Part of it is just the nomenclature, but it is an interesting question because some of this, makes you think differently when you look at it. A lot of times when I think of true chronic angle closure, I'm seeing patchy PAS everywhere. Sometimes people develop a little PAS just if it was a challenging iridotomy and there was some inflammation afterwards. So I just throw that out there because I think it's interesting sometimes how we use the definition and the way we are managing these patients.
Yeah, and actually, I'm going to summarize this at the end because I actually agree with you in this case. This person has a very small area of PAS, so we're looking at a less than a quadrant. I would say in a quadrant you might see some areas of PAS, but elsewhere it actually looked pretty open. And if you look at this temporal angle, I mean, it definitely looks pretty open, and I don't see any evidence of that splotchy type of pigment that would lead me to believe that this patient has some history of PAS. So I 100% agree with you, and I'll kind of move on here a little bit.
Every time you see an iridotomy on a patient, I feel like my trainees always immediately they're a CACG suspect. They have CACG. Right. I'm like, wait. Let's look a little more critically at the angle. Post iridotomy, how open is it? Perhaps this patient, just had a very, had this pupillary block configuration. Once relieved, the angle is sufficiently open. So just very interesting. And I think that's where gonioscopy really is so wonderful. But I will say these images are getting better and better. You can really see a lot. And I will say education for patients, I think team is so key. I think patients really do understand it better when they can visualize what you're talking about. Because it took me years to understand the angle. I still don't know if I fully understand the angle, but these images help.
Absolutely. Just to give you guys an idea on pachymetry, this patient's minimum pachymetries are 441 in the right eye and 445 in the left. So again, this is a huge risk factor for this particular patient. Now I'm going to move on to this patient's OCT. So this is the first OCT and visual field that we took on this patient. This is the example of the combined report, if you haven't seen that there. The right eye is on this side over here, and then the left eye is on the other side, just like so. To zoom in a little bit, let me just sort of talk about that right eye here for a moment. First OCT that I took on him, as you saw from the photographs, this OCT does match up pretty readily with the photographs. As you can see that there's definitely significant loss inferiorly. And we saw that on the photographs where it was very thin in those places and and no longer is seeing anything like Parnathal reflections. And they said this looks as you'd expect it to do. The left eye is actually very similar where, you can definitely see that inferior loss as such. I do want to point out that on my OCTs, I kind of converted to an Enston curve because we know that when it comes to glaucomatous loss, it tends to happen temporally. And in this case, it's very clear to see that inferior temporally in both eyes, that there is significant loss there. That does correspond to what we see on the visual fields. So you can see that this right eye here, superiorly, there's some significant loss there. Although you could argue that this might be a little bit of a cloverleaf pattern. There's quite a few false negatives, but I do believe that this patient does have significant loss in those areas. The left eye, of course, is a little bit worse to the point where we can't even get a pattern deviation on him, but it kind of makes sense to what we see in the optic nerve. I'm going to quickly move on here to the 10-2s, and that's the discussion that we just had as well. As you can see, the patient definitely has 10-2 nasal loss in the right eye and more so in that left eye there. That corresponds to that inferior temporal thinning and corresponding ganglion cell. So let's sort of talk a little bit about staging, and this is an advanced stage of glaucoma because we are seeing loss within the central 5 degrees of fixation based on AGS definitions. So what do we do for this patient? So for this particular patient, I did start this patient on Travatan. I want to see what I can do, which is a prostaglandin, and thinking to myself that I do want to consider adding additional medications to him in the future. Now, I've seen him a few times since, and I want to show you what his IOP graphs tend to be. So these are the first couple of times that we saw him in our primary eye care clinic, and these are the times that I saw him here. Once I started him on Travatan, I was able to bring his pressures down to the mid to lower teens. However, they do kind of bounce back up a little bit. And when I talk to this patient, unfortunately for him, compliance tends to be a problem. As you recall, he kind of felt that the drops really don't help him much. So just to kind of summarize this case that hopefully lead us to some discussion is that we have a young patient. He's 59 years old. He's African-American with severe glaucoma in both eyes, with unknown family history, thin pachymetries in both eyes, and variable drop compliance. So the idea of potentially adding a drop in this case, would this be helpful to him? And I think, let's sort of discuss our options.
Oh man, great case. I'm going to try to, I'm a mentee of Steve Getty, and so I always try to use evidence as much as possible to support my decision-making process, especially when I'm going to need to be more aggressive than I would typically like to be. So you have younger patient, severe disease, poor compliance. I think this patient needs trabeculectomies in both eyes. I think he needs them soon. Why? Look at data from the Collaborative Initial Glaucoma Treatment Study, the new trial called the CACG trial out of the UK, supporting patients who are presenting with severe disease probably do better with earlier surgical intervention. CIGITs looked at patients with a mean deviation of -10 or worse. They did better going right to trab. I think this patient's compliance is an issue. I think this patient's already lost substantial vision. Now, why trab versus tube? Well, starting IOP is not terribly high. And if you look at some of the results of the PTVT, it does point to trabeculectomy probably being a better primary surgery. That's my just very quick summation. I think we have good evidence to support why this patient probably needs trabeculectomy. Now, that being said, there's always the flip side that is a surgery. It comes at risk. And this patient who already is having some questionable issues with compliance, is this patient going to comply with all the follow-up that's needed to do a trabeculectomy in both eyes? That's where building a good relationship with the patient is key. And sometimes you don't have a lot of time to do it, but you got to do it.
How about things like, would there be any benefit to do lensectomies, so do a clear lens exchange, potentially angle-based procedures, or is this patient too far gone?
So another great question. I think angle surgery for me, limited utility when you see somebody with that kind of visual field loss. I think the entire outflow pathway is probably diseased. As we talked about before, when you look at things like the Eagle study, remember, people try to take data from big studies and I think extrapolate the data and make it apply to the patient sitting right in front of them. It doesn't really apply in this situation. The patient's already had iridotomies. I think there's an open angle component to what's going on here. The thin pachymetry, the appearance of those nerves, how open that angle was on gonioscopy. I'm treating this more like an open angle glaucoma patient who does have some focal PAS. I think there's probably some benefit to lens extraction, but not tremendous utility. I think this person needs a low pressure, low, steady intraocular pressure. So that would be my feelings on it. I don't know, Jess, any other thoughts from you?
I think one important thing that you brought up, Anu, is staging of glaucoma, which is something that is often lost in a clinical environment. So thinking about the visual field once again and applying that data to correctly and appropriately staging glaucoma based on AGS and therefore ICD-10 criteria.
And I will bring up one last thing. This is a true severe disease. And by that, I mean, this isn't somebody who has a small point within 5 degrees, who's got an otherwise pretty healthy disc with a deep inferior notch. This person has pretty significant retinal nerve fiber layer thinning with visual field loss in multiple hemifields. This person has true severe disease. And that is something that I do think we can have a whole discussion around, is what really is severe disease. But this person truly does. And I think this person needs some pretty aggressive management.